Hello, and welcome to another episode of Plastic Surgery Unfiltered. I'm your host, Dr. Armando Davila, joined, as almost always, by Dr. David Turer.
Good morning.
How are you doing today?
Great.
So today, we're going to be talking about post-operative recovery.
Yep, absolutely.
Right? And really a lot of the BS that surrounds it.
Yeah, I mean, so when I speak to patients, I think that one of the things that freaks out people the most about elective surgery is certainly the recovery. I think that is maybe obvious, maybe not, but it's such an important part of having a good experience with plastic surgery.
Yeah, absolutely. Recovery is a weird word too, because I don't think anyone's ever really defined what recovery means. And I think that recovery is in the eye of the recoverer, I guess. But I think that certainly it has to do with, when can I go back to sort of being normal, I think is that for most people. Yeah,
I mean, I think that there's this word that floats around on the internet, downtime.
Okay.
And
yeah, I hate that word.
And I'm not sure that people really know what that means.
I don't know what that means.
I mean, we don't. It totally depends on what your definition of downtime is. Different practices, different surgeons, different people may use that word completely differently, and it's really important to understand what that means.
Yeah, and I think that let's take a very common operation, an abdominoplasty or tummy tuck.
I think it's a great example.
And if you ask ChatGPT I'd be very curious. We should ask it real time, what the downtime of an abdominoplasty is. I'm going to take a guess, and I'm going to say it's going to say 6 to 8 weeks.
Yeah, I think that's what a lot of people think it is. But what is that? You're certainly not laying in bed for 6 to 8 weeks.
Yeah, I mean, that's impossible. You're not even if you have work. I don't even think you sit around or can't go to work for 6 to 8 weeks. I think that's absurd.
Yeah, I mean, and I think that is something that probably keeps a lot of people from even considering plastic surgery, is because they say, I work, I've got kids. How could I possibly have this elective surgery if it means that I'm going to have
2 months
of downtime?
Yeah,
and that's kind of ridiculous.
Yeah, and I don't we did actually. We can start there, and I think we'll work backwards towards day zero. I kind of challenge you, because I started doing this thing kind of when I got here, which was 1 month clearance for everyone, right?
Yeah.
And I had introduced that to you, and you said, let me investigate this. And what did you find when you...
So I think it's pretty common practice for something, an abdominoplasty is a great example, because I think some of the teaching in general surgery was that after something like a laparotomy or a hernia repair, that you would avoid strenuous activity for at least 6 to 8 weeks, if not longer, to allow things to heal. But I went through a review of the literature, and as far as I could tell, there is nothing that really supports that. And in fact, there may be some evidence that getting people moving earlier leads to better outcomes in the long run.
Yeah. I mean, orthopedic surgery has made a big push for this kind of literature in the last, I think, half decade, showing that the traditional approaches of immobilization in these very fancy devices, my own wife had this big immobilizer, is actually bad for outcomes. And that, nowadays, I think I don't know what the literature is, but if you get a knee replacement, they're moving you day zero. Yeah. And so...
Well, I mean, I think even in our patients, how many people, we do a lot of outpatient surgery, almost all outpatient surgery. And so people are like, when am I going to be up and moving? And you're literally
the second
2 hours after surgery, because you're going to get up, you're going to get in a wheelchair, you're going to get in your car, and then you're going to walk to your house. You're not just laying in bed.
Yeah.
And in fact, that's how people have really bad complications, like blood clots, like DVTs.
Yeah, absolutely. I mean, I think there's this term in medicine called iatrogenesis or iatrogenic injury. So for the audience, right, I think, we talk about healthcare in the United States and the amount of people that are injured by medical mistakes or whatever you'd call it, or injured by the healthcare industry. And I think this is sort of one of the fascinating things about, our intersection with it. I remember in my training, we used to have people who would do these abdominoplasties, and we'd admit patients to the hospital. And then for convenience, because they were in pain, we'd leave the catheter in. Yep. So then they wouldn't get up out of bed. They would be in pain. They wouldn't be getting their medications at a scheduled dose. They weren't in control of that. And they'd just lie there. And then they started getting blood clots. No surprise.
No surprise.
Because they're not moving.
Yep.
So then the hospital invents these little squeezy pumps to like make sure that when you're not moving, but then no one wears them because they keep beeping and they're plugged into the wall.
They're uncomfortable and they tether you to the bed. So it's one more thing to keep you from getting out of bed.
Exactly, because they're powered by the wall. And so now you can't get out of bed because you're strapped to the things. And so then we started giving people blood thinners. So we started giving people chemical blood thinners to avoid the blood clots that were caused by keeping people in the hospital in bed.
Immobilized.
And then there was a bunch of now bleeding that occurs after abdominoplasty, elective abdominoplasty, because we're giving blood thinners. So that's the definition of iatrogenesis. All this downstream effect that could have just been solved by having the person stand up immediately after surgery. So our blood clot rate is like 0. I mean, and our
virtually zero.
Virtually zero, and our bleeding rate is virtually zero because we just have you get up and move, you know?
Well, and I think that, so when I talk to patients, there's a couple of things that they're primarily concerned about. Like, and again, abdominoplasty is a great example. One of the things people are really freaked out about is the pain after surgery.
Sure.
And I think that the pain, like you had mentioned, the pain after surgery often leads to some of these other problems, because if you are so desperately uncomfortable, you don't want to move. You're just stiff as a board and you're laying in bed. Mm-hmm. And so I think that, you know, particularly in our practice, we've come up with a really, really cool protocol to avoid that.
Yeah, I mean, you're right. Like, you know, I think that you mentioned strenuous activity, and I think that when you start talking about strenuous activity, that is, I think we concluded at this month juncture. Mm-hmm. And so for all our patients who have this, it doesn't matter if you're like, I tell people you can climb Mount Everest after 1 month for all I care. Like, I don't think there's any significant detriment to your surgical outcome for strenuous activity after that. But as you start getting closer, like we start moving backwards in the operation, then when we start saying downtime or recovery, I do think this starts to talk about really pain, discomfort, and sort of normal activity.
Right, exactly.
And I separate it out by, you know, one of the terms in medicine is ADLs, activities of daily living, like washing your hair, cooking yourself food, putting your socks on, et cetera, et cetera. Like, how soon can you do those things? And then obviously there's this sort of, how soon can I do extraneous activities? How soon can I go do my yoga or get on, you know, bench press or go to work at I think those are two different things for you, right?
Oh yeah, absolutely.
So how do you talk to people about that, I guess?
Yeah, I mean, so honestly, I think that in terms of ADLs, most people after most of the surgery that we do are back on their feet and doing those kind of things. I mean, I would say no more than a week at the absolute most, and even that is being very conservative.
Yeah.
I think most people are doing most things independently within a couple of days, frankly.
For most surgeries, yeah.
Yeah, for
like
most
for
things.
For a standard, and that's, you know, you didn't like my 0 to 1, 1 to 2, 2 to 4, and 4 to 6, but I do like to think about time to ADLs that way, where, you know, you have a 4 to 6 hour operation, your time to ADLs is probably going to be 10 days or so, like completely independent, right?
Yeah,
without assistance.
I mean, for certain things, like obviously there are functional limitations. Like if you have a tummy tuck, just bending all the way over may not be possible, or, you know, if you have a facelift, you may not want to be like straining and bending over.
Yeah.
So that's like but it's not like you're not gonna be able to walk around and get yourself lunch.
Sure. But I do think that I call it time with assistance, because some of the things you're going to be limited by. And so I have a theory that it is very related to length of operation, you know.
I mean, some of that's probably also tied to the fact that like longer cases or bigger cases
Sure.
too.
Like,
you know, like a 1 hour breast aug, like people are like often surprised by how not uncomfortable they are. They're like, wow, I can't believe that, you know, I'm kind of back and doing things within 24, 48 hours.
Correct. And I think a breast aug is a great example too. So, but yeah, I think that there's that sort of differentiator for me is, and that's what I personally call downtime, as in you're going to struggle with some activities of daily living.
To be totally independent and back to daily life.
And so, you know, bigger or longer operations obviously have a longer time to that. And obviously there's some nuances depending on the operation, but,
well, and then on top of that, we talk about social downtime.
Correct.
You know, and obviously different operations have different amounts of social downtime, in the sense of, if you don't want people to know that you did something, it may take a couple of weeks, 2-3 weeks for a lot of the surgery we do, even facial surgery, before people without closely inspecting you, are going to know that you did something.
Yes. And that's where this one gets tricky, right? Because when people ask us, like, what's my downtime going to be? I'm always kind of like, well, what do you mean? Like,
right.
what does downtime mean for you? If you're a person who's like, I want to have this thing, I have a public speaking event in like 6 weeks, that's like a different discussion
or if you're getting married in 6 weeks, you probably don't want to have a facelift. Today.
Exactly.
You probably need to give it a little bit more time to recover.
Even if your downtime is only 10 days, right?
Like that part of the downtime.
Right.
Exactly.
And so when people ask us, I do think we try to make sure we understand where they're coming to us with the question.
Right.
And so, people say, well, how long will I be off of work? Okay, well, what do you do for work? Right.
Yeah. Right.
And if you are, you work remote and you work a desk job, 24 hours.
Most people can be back at work within days if they're working from home.
Exactly.
Obviously, if you're, a construction worker and you're doing heavy lifting all the time, then it may take a little bit longer. You may need to modify for a little bit, at least out until that 1 month time point when we kind of liberalize your activity. But I just think that, when you read generically, because we've seen, like you said earlier, we've seen this all over the internet. This operation has this 6 to 8 weeks of downtime. It's like, let's take a step back and look at what that really means, because that's probably not totally true.
Correct. And so I think this is a pretty good segue into what you're discussing, which is as you get even closer to day zero, the biggest thing that is the limiting factor, I think, for most people, and I think this is a good example for the breast dog, is pain, right? Yeah. Like, how long am I going to be in pain? Because pain distracts you. And secondarily, if you're in enough pain, you need to take a narcotic medication, which by law, I have to say you're not allowed to take and drive or commute or work. And so not sort of recommended to be on any kind of controlled substance in those environments.
On top of all of the other, both physical and social side effects that come from narcotic medications.
Sure.
And the addiction potential.
Yeah.
Obviously we could spend an entire podcast talking about that, but I think most people know at this point, narcotic pain medicine is not a good thing.
Yeah, it's not great,
Yeah.
And so, so, and I've been telling patients more and more about this, I have been working on this, and you have joined in on this, for the last 3 years or so, really structuring a protocol for patients that reduces the total amount of narcotic they're using. And it's not just leaving them high and dry, like also controlling their pain.
Absolutely.
And just as a context, when I started here, the average prescription that was given to a patient who had sort of a 4 to 6 hour kind of body lift operation was usually somewhere in the vicinity of 60 to 90 pills of oxycodone 10s. So a massive narcotic dose. We absolutely had historical data of people who had gotten addicted to the medications. Like right away, I said this needed to change, and I saw this in my residency as well.
Yeah, I would say both in plastics, but also in my general surgery training, there were pretty advanced, we called them ERAS protocols, enhanced recovery after surgery, that look to minimize the number of narcotics used.
Correct. And that's how I started. I started with some ERAS study, like looking at ERAS studies, looking at some protocols. And a lot of them, a lot of our literature looked at sort of injectables, numbing medication, other things to sort of enhance the protocol. But that started to evolve. We started to add sort of medications that are over the counter or are non-narcotic prescription medications, but work kind of in combination with each other.
Well, and what I hear all the time from people is they're like, Tylenol doesn't work for me. Advil doesn't work for me. And it's like, okay, I get that, if you break your arm, Tylenol may not be enough to take care of that. But, if your pain is going to be an 8 and Tylenol would take you from an 8 to a 7, and then we use something to take you from a 7 to a 5 or 6, and then from that 5 to a 3 or 4. You're not going to be pain-free after surgery, but we don't want you to be so uncomfortable that you can't move. Mm-hmm. And I think that what we've come up with really allows almost everybody to get there without narcotics now.
Yeah. And I think I love that analogy. It's sort of like the sum of these medications is greater than its individual parts.
Exactly.
And so, and if people really take it the way we intend it to, it is a remarkable reduction. And so, again, for context, we're bearing the lead here, but we went from this like 60 to 90 protocol to, going to about 30 pills. Then we ended up at like around 9 pills over the kind of last year. And now we have some patients taking essentially zero pills, zero narcotic. And so go ahead. You can go over the protocol, I guess, to a certain extent.
Yeah. So the idea is that by putting patients on standing medication, meaning that it's taken on a schedule, as long as that's done reliably, then you never really get to that point where you're having so much pain that you have to take what we would consider a breakthrough medication, which is what we typically give oxycodone.
Yeah, like an emergency dose.
So we typically recommend that people take Tylenol 3 times a day. Obviously the one downside of Tylenol is that you can exceed the maximum dose for the day if you take too much, but taking even 1,000 3 times a day is just fine. We use Celebrex, which is kind of like, I describe it as Motrin's big brother. It's an anti-inflammatory and a great pain medicine. The other cool thing about Celebrex is that it doesn't lead to any increased risk of bleeding, which, things like Motrin
and ibuprofen can.
May or may not, but there's some question about that. And then the last thing that we've added most recently, which is really, really interesting, is called Dronavix. So Dronavix is the first of its kind. It's a novel medication. There's never really been another medicine that works this way, but it works by blocking a particular sodium channel that's only found in peripheral pain nerves.
Yeah, the 1,4 channel.
And so it sort of stops that transmission of peripheral pain. So we have patients take Tylenol, Celebrex, and Dronavix morning and night. You can take Tylenol during the day. The other medicines have a long enough half-life that it kind of covers you throughout the entire day. Yeah. And in addition to that, we also give kind of loading doses of that before surgery. And so we've even found intraoperatively, our anesthesiologists tell us, man, we're given like baby doses of fentanyl intraoperatively. And the patients wake up way more awake, way more alert. And it's really, even from that first moment, has improved their recovery.
Yeah. And, when we say awake, we don't want you to wake up during surgery. Naturally, there's medications that we use to keep you asleep, right? And those are the things you kind of breathe or the medications that go through IV. But naturally, your body is sensing a pain response during the operation. And so we have to give you narcotics during the operation. And so, again, those narcotics are usually responsible for the majority of the side effects that people feel after surgery. The constipation, the rashes, the itchiness, the grogginess, the kind of just like overall obtunded or kind of bad feeling. Yeah. And so if we reduce those, the patients kind of feel better, can recover better, and it shortens, again, your downtime, so to speak, your recovery right. Because you don't have that kind of groggy feeling. And so, you talk about a breast augmentation, right? And a breast augmentation is a surgery that can fundamentally have someone have the operation. It's an hour-long operation, receive almost zero narcotic during the operation, receive zero narcotic after the operation, and essentially go back to normal life
within
a
24
day,
hours,
24 hours,
basically.
Right?
Yeah.
And so it just completely changes, the game. And so, we had implemented this protocol, and I had gotten pretty happy with it. And I said, well, I guess we need to put it to the test. And so,
I'm excited for you to kind of share what you did.
Yeah, so I decided to put it to the test on myself, okay? And so I decided to have a procedure, okay, like a surgery. And I didn't want to make it like a big surgery, but a small scope surgery just to see how these smaller 1-2 hour procedures can sort of like be executed with this. And so I did. I had the surgery. I had it under our advanced local anesthesia, so our wake protocol, and I have lots of videos of me kind of like semi-drowsy under a drape. We'll post those on Instagram later. And I did all the steps. I did the loading. I did all the stuff. And I mean, it's just fascinating. Like I was nervous about having pain because I've had surgery before.
Sure.
And so I ended up taking a oxycodone the day of the procedure.
Yep.
And I still recommend that for most people. But I didn't need it. And it just made me feel, I got all itchy, just felt uncomfortable.
You felt
I was like,
groggy and you felt like crap.
I felt like crap. And I was like, I didn't even need this, right?
Yeah.
And essentially it was crazy to compare to another surgery I've had where when I was in pain, I was like sort of searching for pain medication when that pain started to creep up.
And in that situation, all you had was a narcotic.
Sure.
And so that's what you reach for.
But I've been taking my scheduled medications in the morning and the afternoon and my Tylenol in between. And there has never been a single moment where I've said, oh my gosh, I need to go get pain medication.
Well, I think, there was this concept that was pushed not necessarily by the medical community, but by the makers of narcotics to stay ahead of the pain. And there was this concept that, even nurses and healthcare providers were taught, and they would tell patients, you want to stay ahead of the pain. So you're going to take these narcotic pain medicines on a schedule. And it turns out that led to a lot of problems, a lot of the issues that we see now. But I believe in that. I think we totally believe in that concept of staying ahead of the pain. You just stay ahead of the pain with medicines that have much fewer side effects. So with our triple protocol, you're staying ahead of the pain. You're being proactive about it, but you're not having to use the medicines with the more dangerous side effects.
Yeah, and so like it essentially it takes the discomfort from the surgery to completely unnoticeable, right? It's something you don't actually even know it is happening on a day-to-day basis. Like, I'm up, I'm about, I'm doing my stuff. I don't know what the instinct is to clean the minute you have a surgery, but I felt it and I started cleaning my apartment. And so, but I'm doing that and I have no notice of pain. Right. And so, and that's a pretty incredible feeling I have to remind myself to take the medicine.
If you're moving around or you may feel a little ache, you may feel something, but it's not so excruciating that you're like, I just got to lay in bed. You're back to living your life.
I mean, to be fair, I've had sprained ankles that hurt worse than this.
For sure.
Yeah. And where I have like, oh my gosh, I have to like splint my ankle. Like here, I'm just doing my stuff. And yeah, occasionally I might feel a little twinge of discomfort, but it's not, I mean, it has been quite eye-opening to kind of undergo the process.
Yeah, absolutely. I mean, and I think that's the feedback we've had from our patients is that people came in with a certain expectation, largely because of what they either heard from their friends or they heard online, and they used our recovery protocol, and they were very underwhelmed with the amount of discomfort that they had.
Yeah.
And so, again, part of plastic surgery, this is elective surgery, is for people to have a good experience. And if people are miserable and uncomfortable afterwards, that's not fun. That's not great.
And it doesn't have to be that way.
And it totally doesn't have to be that way.
And that way, like, one of the goals and philosophy of this organization and this company is that we want to make this as like being your best self should not, like, I want to make it as accessible as possible for people to feel their best selves.
It should be accessible to as many people as possible.
And if you have a job that has, a lot of restrictions, or you're worried about pain and discomfort, or, you're worried about the time off you're going to take, we have ways to kind of alleviate all of that.
Yeah. I mean, we get that most people don't want, if you think that you're going to be off at work for 6 weeks, most people can't do that because we got to work. People got to make a living. You got to take care of your family, whatever the situation may be. But, I think if people realize that you can kind of be back to life within days or a week or whatever it is, it becomes a lot more accessible to people.
Yeah. Within a week, I think. And so I think that's the punchline of the thing is most procedures that we do here, most like standard, again, I think like the 2 to 4 range that I think about is about a week of recovery, and again, most of that week of recovery, it has the potential to be completely non-narcotic based. So you're kind of hanging out and Netflixing, but you're not uncomfortable. You're not, laying in bed. You're probably up and about. And as long as you're not going to do any kind of crazy strenuous activity, you save that for 1 month. Right. Most people can do nearly anything they want to do. And I think that's the reality of it with these advanced protocols. And, we're now going even one step further and starting now a lot of other enhancements. We're trying to, and that's part of that recovery like package that we're trying to do for people, like see if we can get their nutrition up and their protein intake up and reduce the number of delayed healing incidents they have, reduce the chances of infection. And we have a lot of healthcare workers with MRSA. And so now we're trying to take it even further. How can we enhance it as much as possible? Because it really is a journey. It's not just surgery.
Well, I think, and people may wonder kind of how we came across or decided upon all this. And this I think is very much where our engineer brains kind of fit into things. We've been very systematic about taking things one step at a time and seeing what really helps, what doesn't, what maybe you think might help and doesn't. And so these recovery protocols that we've come up with have been very systematically designed to help our patients improve their experience after their surgery.
Yeah. And I mean, I remember we did like, I tried that dexamethasone Precedex cocktail. We tried, the Vivicaine cocktail. We tried Exparel. We tried injectables. We've tried a lot of different things. Yep. And we slowly add and remove. And that's why it's taken, 2 to 3 years to kind of get us there. But it is pretty solid at this point. And people do not have to be afraid of it.
Yeah.
It's something like, if this is something you've been interested in and that's what's holding you back, like we can help.
Yeah, totally agree.
So, well, yeah, I mean, we'll kind of wrap up here, but I mean, I think that the experience has been really fantastic with my procedure, my surgery, and looking forward to seeing kind of the rest of the process evolve and really enhance it, even from the small things I've noticed. So thank you again, guys. This is Plastic Surgery Unfiltered, and I'm Dr. Davila and Dr. Turer.